Hello everyone and welcome to a video on Paediatric Oncology. This is part of the Paediatrics unit. So we're going to start off by talking about leukemia. Leukemia is a hemopoietic malignancy of either lymphocytic origin or myeloblastic origin. The most common childhood malignancy is your ALL, your acute lymphocytic leukemia. This is actually more than AML, your acute myelocytic leukemia. ALL is most common in non-Hispanic white men between 2 and 5 years of age, whereas AML is actually more frequently seen in black boys throughout childhood, a slightly older epidemiology of AML. It is associated with trisomy 21, that's very important to know. Trisomy 21 Down syndrome patients are at increased risk of ALL. Also, Fanconi anemia we discussed in the pediatric hematology, prior radiation, and patients with severe combined immunodeficiency, and also some congenital bone marrow failure states as well. ALL generally in children has a good prognosis, with the 5-year survival rate being more than 85%. Just a quick key fact, ALL is the most common childhood malignancy, but following that, it's some of the CNS tumours which we'll discuss, and then also some lymphomas as well. Regarding what to look out for in terms of physical exam and history, symptoms are usually abrupt with ALL, okay, whereas some other leukemias it's more insidious. They are initially non-specific, so a patient's going to suddenly have anorexia, fatigue, and are usually accompanied by things like bone pain. The bone pain is due to the malignant lymphoblastic cells infiltrating the bone marrow. So the patients may present with things like a limp, refusal to bear weight, and also fever, and the fever's from the neutropenia, the so-called neutropenic fever. CNS metastasis may be associated with things like headaches, vomiting, and papilledema, and the ALL actually does have common metastasis to the CNS. AML obviously can present with things like chloroma, a greenish soft tissue tumour of leukemic cells on the skin or the spinal cord, but this is quite rare. AML doesn't usually present with a chloroma. Regarding your diagnosis of a leukemia, generally speaking, you're going to start off with a physical examination. You're going to be seeing signs such as ecchymosis from low platelets and petechiae, pallor from the low anemia, and hepatosplenomegaly and a lymphadenopathy may be present. In terms of your labs, first things that you're going to do with most hematology oncology things is you're going to do your full blood count. And you may see things like a pancytopenia here. What I do want to mention is that while you can see pancytopenia, so that's lowering of hemoglobin, lowering of platelets, and lowering of white blood cells, you may actually see an increase in white blood cells, okay? So the white blood cell count is variable in the leukemias. It can either be high or low, okay? So don't look at that one so much, but look at the anemia and the platelet, the thrombocytopenia. You can also do some coagulation studies because the patient's likely to have signs of ecchymosis and petechiae, and you're obviously going to order your smear, which you always do anyway. The blood work frequently shows high numbers of blasts. As I've mentioned already, this is your lymphoblasts in ALL and myeloblasts in AML. And as I've already said, white blood cells are variable in their count. A bone marrow aspirate and biopsy is then done after, okay? And what you're going to do with this is you're going to be doing, obviously, you're going to be doing some microscopic evaluation of the bone marrow aspirate, but you're also going to do immunotyping as well. The first thing you're going to check for is your terminal deoxynucleotidyl transferase. This is the so-called TDT, and this is essentially something that will be seen on lymphocytes, okay? So in your ALL, you will see a positive TDT, okay? Genetic analysis can also be done as well, because each ALL variant, so if you end up going into hematology, you'll see, and oncology, you'll see that there are so many different variations and subtypes of AML and ALL. And a lot of these are based on the chromosomal translocations, the specific genetic mutations. So doing genetic analysis will enable you to identify which subtype of ALL and AML the patient has. So the genetic analysis and the immunophenotyping will be confirming the diagnosis and also assessing the risk status to inform treatment. The diagnosis is made if the bone marrow is hypercellular with an increase in lymphoblasts, and you're usually looking at more than 20% of the bone marrow cells being blasts. Okay, that's usually required for a diagnosis in both AML and ALL. Some things that you should be doing also is chest x-rays. The reason is because they might have a thymic mass. You can also be doing CTs or brain imaging if you suspect that there is cerebral metastasis. You can also do a testicular ultrasound if you think there's metastasis to the testes. This is actually quite common, especially in ALL. And you can be doing other tests depending on signs and symptoms. But the main things that you need to be doing is full blood count, smear. Then once you suspect AML or ALL, you do bone marrow aspirate, TDT testing. You can also do, so TDT I said was positive for ALL. You can also do an MPO, which will be positive in AML. Okay, so that's just another thing you can do in AML rather than the TDT for ALL. Regarding your treatment, it's chemotherapy based, of course. We're going to have an induction chemotherapy, consolidation, and maintenance phase. Intrathecal chemotherapy can obviously be used for neurological prophylaxis, and it's generally added to treatment regimes. So that's a question that can definitely be incorporated into your board exams, because you'll be thinking, oh, well, there's no signs of CNS metastasis, I don't need to do intrathecal chemotherapy. But the trick there is that we actually can give it prophylactically. This is more for ALL than AML. Always keep an eye out for tumor lysis syndrome. This is very common during the initiation treatment stage of cancers with high cell turnover, like leukemias and lymphomas. So what happens here is that because we have this chemotherapy rapidly killing off loads of cancerous cells, we get a lysis of these cells in a short period. And this is going to release the content of these cells into the bloodstream. So what do we get? We get a release of potassium, a release of phosphate, and a release of uric acid. The phosphate being high will cause the calcium to be low because it's going to bind free calcium. So we get this tetrad of hyperkalemia, hyperphosphatemia, hyperuricemia, and hypocalcemia. Okay? And it can result in things like renal failure, arrhythmias from the potassium, and even death. How do we treat it? This is high yield to know. We treat it with fluids, of course, diuretics, okay, and then rasburicase as well. Rasburicase is a uricus uric, and that's going to decrease the risk of urate nephropathy. We can also give allopurinol, which is our xanthine oxidase inhibitor. This is used usually as a preventative therapy, okay? So when you're giving your induction chemotherapy, you can give allopurinol with it. But rasburicase is actually more effective if the patient has tumor lysis syndrome, okay? Corticosteroids may precipitate tumor lysis syndrome as well, so do look out for patients taking corticosteroids as part of their regime, okay? Just a quick mnemonic for tumor lysis syndrome: puke, calcium, phosphorus elevation, uric acid elevation, potassium elevation, and the E stands for elevated, and then the calcium can be decreased. But if you remember these three, you should know calcium will decrease because of the high phosphate. Excellent, moving now on to the neuroblastoma. Okay, so a neuroblastoma, again, is another very common pediatric tumor. It's an embryonal tumor that arises from neurocrest cells. It comes from very similar cells of the pheochromocytoma, okay, but it comes from the more neuronal origin of the cells rather than the adrenal medulla chromaffin cells that pheochromocytoma is going to derive from. More than 1/2 of patients are below 2 years of age, which is significant, and 70% have distant metastasis at presentation, okay? Neuroblastomas are associated with neurofibromatosis. They are associated with Hirschsprung's disease, Beckwith-Wiedemann syndrome. If you remember, Beckwith-Wiedemann syndrome is also associated with Wilms tumor as well. And it is also associated with the expansion of the N-mice oncogene. And a quick pop quiz question for you is, which cancer is associated with the C-mice oncogene? Excellent. put it in the chat and we hopefully can get the right answer on that. So, in terms of history and physical exam, tumours can be located anywhere along the sympathetic chain, but most commonly they're going to be in the adrenal medulla, okay? Because as you know, the adrenal medulla is like your postsynaptic ganglion. So it's like equivalent of a postsynaptic ganglion. You're going to be having presynaptic sympathetic nervous system nerves linking onto the adrenal medulla. So you can get them in the adrenal medulla, and that's where you most commonly find them. You can also find them in the paraspinal region as well, but technically you can find them wherever you have sympathetic chain, so thorax and even cervical as well. Symptoms may vary with location and may include things like abdominal distension. This is quite common, with a firm and irregular abdominal mass that may cross the midline. The reason why I stress may cross the midline is because when you have an infant where the mum or the dad is bathing the infant and maybe they palpate an abdomen mass, your main two differentials, just for the sake of board exams, is Wilms tumour and neuroblastomas. Wilms tumour will stay on one side of the midline, whereas your neuroblastomas can cross the midline. Okay, so keep that in mind. If it's in the cervical chain, you can get Horner syndrome. You can also get hypertension, although this is way less common than in pheochromocytoma. And then you can get this very, very nice, famous disorder called opsoclonus myoclonus ataxia, which is also called dancing eyes and dancing feet syndrome. Okay, we may even get core compression from paraspinal tumours as well. Patients can have anemia, failure to thrive, and fever accompanying that, and more than 50% of patients will have metastasis at diagnosis, which we've already said. And signs can include bone marrow suppression, proptosis, hepatomegaly, subcutaneous nodules, and opsoclonus myoclonus syndrome. So for your diagnosis, the diagnostic procedure is biopsy, okay? Somebody has a mass, maybe around the kidneys, in the adrenal area, maybe in the paraspinal areas. You've got to biopsy it, okay? And histologically, you're going to be seeing small, round, blue tumour cells, okay? Primitive neurocrest cells, and the characteristic rosette pattern. And you may also see, something that's not mentioned here, but you may also see a Schwannian stroma, okay? A Schwannian stroma. And essentially this is what you see here, I believe. Do check with a proper histopathologist, but I believe this is the Schwannian stroma, okay? And when you have more Schwannian stroma, or the presence of a Schwannian stroma, this is a good prognosis, okay? This is a good prognosis. But generally look out for rosettes and small blue tumour cells. Other things that you can look out for is the 24-hour urine catecholamines, so doing a 24-hour urine test and checking for vanilla mandelic acid and homovalinic acid. These are essentially breakdowns of catecholamines that you should check for. And then obviously you should be doing CT scans and MRIs if you suspect a tumour. Another thing that you can do is an MIBG scan and a bone marrow aspirate. This is essentially just to check for metastasis, okay? I believe the MIBG scan is also something we do to check for pheochromocytoma metastasis. So yeah, but this order that first aid has put it in is very wrong. I mean, the first thing you're going to do if you suspect it is this, either the catecholamines in the urine and a scan, and then after that you will do the biopsy to confirm the diagnosis. Then after that you can do the other scans to stage. Regarding treatment, local excision plus post-surgical chemotherapy, okay, and neoadjuvant chemotherapy, okay, and maybe a bit of radiation therapy as well. Now we're going to come on to Wilms tumour. So Wilms tumour, as I said already, big differential for that adrenal or renal mass that you palpate in an infant. So it's a renal tumour of embryonal origin from the metanephros, okay? So when we talk about development of the kidney, we have the ureteric bud that comes out, and then we have the metanephric blastoma, which comes from mesoderm. The ureteric bud, which is from endodermal origin, is going to be going into the metanephric blastoma. They exchange signals, and that's going to be creating the metanephros, which then becomes your functioning adult kidney, okay? And Wilms tumor is essentially from this metanephric blastoma. And it's commonly seen in children 2 to 5 years of age, and it is associated with a couple of diseases. It's associated with Beckwith-Wiedemann syndrome, where you see signs of hemihypertrophy, macroglossia, visceromegaly, ear pitting, and also Wagner syndrome as well. And I'm going to try and remember what Wagner syndrome stands for. I believe it stands for Wilms syndrome, aniridia, okay, which is an eye defect, and then I think growth retardation, I think, but please do double check that. That's just on the top of my head. Risk factors also include a positive family history and also horseshoe kidney as well. It's right here. So Wilms syndrome, Wilms tumor, aniridia, genitourinary abnormalities, and then mental retardation. So I got the last bit wrong, but that's your Wagner syndrome. Just in terms of your history and physical examination, you're going to be looking for a patient who's usually asymptomatic, but most of your USMLE questions are going to have a non-tender, smooth abdominal mass that does not cross the midline, okay? Whereas your neuroblastoma is usually smooth, non-tender, but it's usually more irregular and it crosses the midline. Patients may present with signs of abdominal pain, maybe even fever and hypertension, especially if there's renal compromise, and sometimes even microscopic or gross hematuria as well. Regarding your diagnosis, the best initial test is abdominal ultrasound. This should make sense. I don't want to go straight to a CT, especially if the patient is a child, which they most likely will be, but the most accurate test will be your biopsy. And in Wilms tumor, I know histopathology is not so important here, but you see a tri-phasic involvement of different cells, okay? So you're going to be seeing a metanephric blastomal component, so like a almost mesoderm origin component, and you're also going to have a, to be honest, I'm not actually 100% sure. I used to remember this a lot better, but I think you have mesodermal elements. I think you have primitive neuro crest elements maybe. So please check that out. But there's essentially 3 different cell types that you usually see. So check that out. Once you've established a diagnosis, you can then of course do further testing like CT scans of the chest and the abdomen just to check for metastasis and stage the disease. Regarding treatment, local resection and nephrectomy with a post-surgical neoadjuvant chemotherapy and radiation, depending on stage and histology. Now we're going to be discussing the childhood bone tumours. So bone tumours can either be primary or secondary, i.e. they can be a primary bone problem or they can be metastasis. Primary bone tumours are most common in the paediatric population, okay? Whereas when you see adults, you're usually talking about lung cancer metastasizing to the bone, prostate cancer metastasizing to the vertebral column, these sorts of things, okay? They can either be benign or malignant, and the malignant tumours are important to recognize and treat promptly. The main differential that we're going to be discussing is Ewing sarcoma versus osteosarcoma, okay? And in the musculoskeletal unit that we've covered, I discuss in more detail about the other benign and malignant bone tumours. But just for sake of paediatric oncology, we're going to be discussing Ewing's and osteosarcoma. So you have a case. Let's discuss osteosarcoma first. Osteosarcoma is from your osteoblasts, okay? It's mesoderm origin. It's most commonly seen in Hispanics and white men. This is the peak, and it peaks usually in the kind of adolescent phase, 13 to 16 years old. The most common initial presentation is a local pain and swelling. Systemic symptoms are very rare, but it's like a local swelling where the tumor is. It's most commonly found at the metaphysis of the long bone, usually seen around the knee, so around the distal femur and the proximal tibia, these kind of areas. It can also be seen in the proximal humerus, but usually it's seen around the knee. And the really important thing to remember is the likelihood of metastasis to the lungs in osteosarcomas is high. In terms of your diagnosis, you're probably going to start off, because it's going to be a bone pain, you're probably going to be checking like ALP and maybe a couple of other things. You're going to find ALP to be high. You will be doing maybe x-rays of the lesion, and you see the characteristic sunburst appearance and Codman's triangle. So as you can see here, we have this sort of sunburst appearance, and Codman's triangle is essentially where the periosteum is lifted up from its bed, and this is essentially a periosteal reaction, and that's essentially the Codman's triangle that you can see. An MRI of the entire length of the affected bone can be done. CT of the chest should be done to rule out pulmonary metastasis. This is very high yield to know. And you can also do a radionucleotide technetium bone scanning to assess the rest of the skeletal bones for imaging, for lesions and potentially distant metastasis. Regarding your treatment, you can do local excision and chemotherapy. Now let's talk a little bit about Ewing's. So Ewing's is not from osteoblasts. Ewing's sarcoma is from neuroectoderm, okay? And it is associated with a translocation of 11 to 22, all right? It's most commonly seen in white men, usually between 10 and 20 years of age, so a very similar epidemiology. It presents very similar to that of osteosarcoma, like local pain, swelling, and also systemic symptoms can be seen, and these systemic symptoms are more common than in osteosarcomas. It's usually seen at the diaphysis, not the metaphysis, okay? So it's usually seen at the diaphysis of long bones. In terms of your diagnosis, you will be doing, usually you can see leukocytosis here and a high ESR, which is kind of unique. Your imaging that you do, you will see an onion skin, which is essentially a periosteal reaction of the X-ray, which essentially you can see here. It kind of looks like onion skinning, okay? There's layers to it. And then CT scans of the chest should be done to rule out pulmonary metastasis again, and a radionucleotide technetium scan can assess the rest of the skeletal bones. For treatment, we can be doing local excision chemotherapy, but this time it's more radio vulnerable, so radiation can be done. The final disease I want to talk about is quite a rare disease called Langerhans histiocytosis, and this is a rare pediatric malignancy that results from abnormal proliferation of histiocytes, okay? And histiocytes are essentially activated dendritic cells and macrophages. So histiocytes are cells that are destined to be in the skin, okay? They are destined to be in the skin, but of course, histiocytes, they can be in the bone marrow before they migrate to the skin. So if you remember, dendritic cells are your local skin macrophages, okay? So we have a proliferation of white blood cells that are destined for the skin. So the two areas that this is going to be affecting is the bone marrow, where the dendritic cells are made, but the skin, where the dendritic cells are ending up, if that makes sense. So in terms of presentation, the disease can present with single or multiple lesions. Common presentation is a solitary, painful lytic lesion surrounded by edema. We have the very well-known tennis racket granules seen on pathology. So they kind of look like this. Okay, these are called Burbeck granules. Burbeck granules. And these are pathognomic. And these can be seen on pathology, so you'll biopsy it to get a diagnosis. And if you have a single bone lesion, this is typically treated with surgery alone. Langerhans histiocytosis is very rare and it's not that commonly tested on your boards, but there's lots of different forms of Langerhans histiocytosis. We have something called Hans-Schüller-Christian disease, and we also have other diseases. But I just want to point something out. There are specific areas that these lytic bone lesions have favorable locations for. They like to go to the sella tunica. And if you remember your cranial anatomy, the sella tunica is where the pituitary sits, okay? So a lot of patients with Langerhans histiocytosis end up getting diabetes insipidus. Okay, so if you have a young child with diabetes insipidus or signs of diabetes insipidus and lytic bone lesions in the skull, then you should be looking at Langerhans histiocytosis. Also, if you are, another couple of few areas is the orbit, okay? So signs of proptosis is very common, so look out for that. And then other areas is also in the jaw, potentially in other bones, but the ones I would look out for are places like the sella tunica and the orbit, okay? And generally speaking, most of them don't cause these signs, but just for the USMLE, remember those, because there are a couple of UWorld questions that have tested on that. So I hope that was helpful, and on to the next.